Hello, now we would like to start our public health policy impacting on families and communities session. Our keynote presenter will be Dr. Bayless Walker. Dr. Bayless Walker is a professor of environmental and occupational medicine and toxicology at Howard University College of Medicine. He is a former professor of environmental health at the School of Public Health, State University of New York in Albany. He has served as Dean of the Public Health faculty at University of Oklahoma Health Sciences Center and former Commissioner of Public Health for Commonwealth of Massachusetts and Chairman for the Massachusetts Public Health Council. Dr. Walker is a past president for the American Public Health Association and a distinguished fellow of the Royal Society of Health, London, England. He has published extensively on environmental and occupational risk factors of disease and disability. He is a National Institute of Health advisor on environmental and community health aspects of biodefense research and senior science advisor, environmental health, to the National Library of Medicine. I introduce to you Dr. Bayless Walker.
Our focus is on health education. Okay. The challenges that we are confronting in the area of health education. Could you ask? No. Here's just an example of some of the challenges. There are challenges because there's a lot of misinformation out there. There are a lot of doubters out there. And here are some examples. That vaccination causes autism, that unpasteurized milk does not cause illness, genetically modified foods are evil, etc. So we have to revisit, or re-emphasize, or re-energize the whole field of health education. And let me give you an example of why health education is such an important factor. First, in our broad societal attack on disease problems, using all available means that we call public health or population health, there are three avenues now open to us. One is health care, which in present language is the Affordable Care Act. Environmental measures, which needs no explanation, and health education. For example, in the case of automobile accident, the health care dimension of that is emergency medical services or rehabilitation of the injured person. The environmental component, the environmental measurement aspect, is construction of highways, construction of automobiles. And in each of these areas we have seen a lot of attention in recent years. And the health education component is driver training, teaching people rules of the road in order for them to better maneuver their way around a community to avoid accident. This triumvirate is complementary. And over the years, we have come to appreciate the complementarity of these three components. And even though there are changes periodically in various aspects of these areas, advances made because of advances in science and technology. The whole environmental measurement field is one that where we've seen a lot of changes. And yet we all know that practically all diseases have an environmental cause or environmental factors or environmental component. In recent years, we have seen a considerable emphasis on STEM. Everybody can tell you what STEM is. And to the point that some lawmakers have come to appreciate the fact that STEM, science, technology, mathematics, etc., and that has begun to dominate the education system. So much so, click that, we have come to recognize that lawmakers at the state level in some states are beginning to say, look, let's put more emphasis on STEM because this is what we need in order to move the economy of the country. And therefore, some states are beginning to downplay some aspects of the educational system, the humanities. Let's put more money into STEM. At the same time, we face a paradox. And the paradox is this. Even though we have made substantial progress in communications, in literacy, we are confronted with a paradox in that we have large amounts of information, health information, health protective information, etc. And yet there seems to be this gap in the information that's available and the people's use of it. And one example, or two examples jump out immediately. We have invested considerable resources in obesity reduction. And yet, earlier this year, there was a report that indicated that obesity had not declined. That's the paradox. And yet we know there's loads and loads and loads of information through many channels that are aimed at what? Reducing obesity. But somehow that has not had an effect on the incidence or prevalence of obesity. Another example is tobacco use. Everybody recognizes that we have invested considerable resources in attempting to encourage smoking cessation. And yet, tobacco remains the underlying cause of the leading cause of death in the United States. So we can go on and on with those kinds of examples, that the information on protecting our health, the information on doing things that will reduce the risk factors, such as tobacco consumption, alcohol consumption, etc. We know those. We know that these are important factors in disease causation. Stroke is another example. You can advance that. We still, even though we've made substantial progress in reducing stroke, we still have a fairly high incidence of stroke. And yet we know, without any new medicine, without any new research, we know the factors that can be controlled in order to reduce the incidence of stroke. And so that paradox is a puzzle. That paradox cries out as a challenge to health education. I think it is clear that health education is a tool of disease prevention. It is an effective tool of prevention. And although the definition of health education has changed over a period of time, through time I should say, we know that the end point of health education is not an awareness of facts. It's easy to give out the facts of a particular disease, but it is an emotional conviction with both attitudinal and behavioral change and insight. In fact, that was one of the earlier criticisms of the field of health education, that we were simply printing pamphlets and passing out information and investing in public service announcements, giving out the facts. But there has to be more than just that. One thing is very clear, and that is the link between health outcomes and education is firmly established. The literature is very rich with any number of studies which show that there is a link between health education, literacy, and health outcome. Therein lies the challenge of health education. The point I was making earlier was that there are lawmakers who argue that competition, along with demands for the U.S. economy, are driving the STEM emphasis. A lot of money has been put into STEM, and there's probably been more conferences and more discussions and more symposia on STEM. Let's get kids into STEM, and yet here we stand with a big gap in health education of what we know and what we practice and what the outcome is. Go ahead. So this is the paradox that we face, and that is why this discussion is focused on health education, the challenges of health education, which seldom gets the visibility of the play that STEM education gets, because the workplace is calling for technical folks, technicians in the engineering and math, those areas, science, that are dominating the scene. I did a quick and interesting survey and ran through the papers over the last 3 months, and there's probably been more information on STEM than practically any other topic we can think of. Congressional hearings on STEM, seminars on STEM, but we have this paradox of knowing how to reduce the incidence of diabetes, but not translating that information into actual reduction of diabetes. And the same holds for tobacco smoke. Go ahead. I mentioned earlier about health education in the context of population health. And this is what I simply said. There are these 3 main avenues open for us in our effort to reduce the incidence of disease and dysfunction. And those 3 avenues, I'll repeat: personal health care, often called medical care, environmental measures, and health education. These are the 3 means that we have to deal with these problems. And yet, health education does not seem to get the kind of emphasis that is needed in order to have an impact on the population of the U.S. Next slide. These are points I was making earlier before we got the slides operating, but go ahead to the next slide. Here's a challenge that everybody's aware of, and that is the vaccine skeptics are on the rise. People who are skeptical about vaccination that has stood the test of time. People who are skeptical about vaccinations that have been an effective approach to the prevention of diseases, childhood diseases, measles, mumps, and the list goes on and on and on and on and on. Why do we have these? Who are these skeptics? They are parents who believe or disbelieve the fundamental science of immunization, which has proven itself time and time and time again. We're begging now for an agent to alter the course of the Zika epidemic. So throughout history, vaccination, immunization have been and continues to be an effective tool. And yet we still have segments of the population that believe that vaccines are not effective, that if you vaccinate your child, the likelihood he or she will get a disease, or he or she will have some kind of disorder. But as we point out here, there is a lack of access to information, and perhaps I should say a lack of translation, interpretation, and understanding of the information, the misinterpretation of available information. And there are groups, as many of you well know, groups that perpetuate these arguments against vaccination. And this issue was elevated into sharp relief by an outbreak, an outbreak of measles at a California Disney park. Major outbreak that prompted the governor of California to sign one of the most stringent laws in the United States, almost ensuring that 100% of the people in the state of California would be vaccinated. Some parents worry about the adverse effect of vaccines, and yet we fail to realize, and it's very well publicized, that vaccines undergo very extensive and continuous surveillance to detect adverse effects overlooked during the clinical trials, the testing of the vaccines that you heard, using the process that you heard the earlier speaker talked about. Go ahead. The other issue that offers a challenge to health education, and this is an old one, but it has gained momentum, it has gained interest, and there is the allegation, I call it an allegation, that the raw milk market is booming. That people are turning away from raw milk, turning away from pasteurized milk to consume unpasteurized milk. Now here is an area in which there's no question about the epidemiology. The epidemiological basis is very secure, and we've had many, many years of this experience in preventing diseases. We know that pasteurization is an effective intervention in the prevention of milk-borne diseases. But there are, and I'm not criticizing the group, but there is the group called the farm-to-table group, who thinks that raw milk is far better for you nutritionally than pasteurized milk. The evidence there rests on a very insecure epidemiological foundation. But the foundation for the effectiveness of pasteurized milk in preventing milk-borne diseases, that foundation is secure, going all the way back to the 1800s when Pasteur first introduced the pasteurization of milk. Go ahead. Another issue that falls under the umbrella of health education challenge is genetically modified food. And this refers to plants and animals with an altered genetic makeup. They alter the DNA, and they do it for various purposes. Longer shelf life, disease resistant, and different colors and flavors. That in no way, other than genetic makeup, alters the nutritional quality, etc., of the food. And yet there are people who are nervous, go ahead, about genetically modified food. Unfounded concern, meaning unfounded, there's no epidemiological or scientific basis for the concern. People are afraid of health risk. They think somehow by manipulating the genetic of plants technologically. Now we see natural alterations in genetic makeup for plants quite often. It happens out in the world. People are concerned about the effects on the environment, concerned about what could result from tampering with nature, as they call it. These are unfounded concerns, unfounded because there is no sound scientific or epidemiological basis for that. But it does create a challenge for a health education challenge to try to change people's thinking about these foods. Next slide. And here's the other issue that I mentioned, and that is stroke. Every year, strokes kill millions of people and leave millions or more prematurely disabled. And yet, we know that there are certain factors or certain procedures that can reduce the incidence of high blood pressure and stroke. And we know a great deal about that without inventing one additional medication. We know that. So, in summary, Dr. Warren, I'm entitled to 10 more minutes because it's not my fault. I'm joking. So these then are challenges in the health education field. And we can put as much emphasis as we want to on STEM, on technology, engineering, etc. But if we do not address, and I just scratched the surface merely, we do not address the health education challenges and problems, then STEM will not be important for many of us because we have failed to implement health education, educating the public so that they understand how they can protect their own health and access the tools and knowledge that we have available regarding health promotion and disease prevention. Thank you very much. Thanks. I'd like my USB.
I gave you this pulled up on the computer.
Okay. All right, thanks.
Next, we will have our responder, Dr. Emmanuel Taylor. Dr. Taylor is the health scientist, administrator, and leader of the Performance and Evaluation Core in the Center to Reduce Cancer Health Disparities at the National Cancer Institute. He has over 25 years of experience in public health program planning, implementation, and evaluation at local, community, national, and international levels. Prior to joining the Core in the Center to Reduce Cancer Health Disparities, Dr. Taylor was president and CEO of Health Information Management Associates, Incorporated, as well as the chief epidemiologist and director of health informatics research and program evaluation at HIMA, H-I-M-A. He was an associate professor of public health at Morgan State University and Senior Epidemiologist for Minority Health at the Centers for Disease Control and Prevention. He earned his doctorate in International Health Epidemiology from the Tulane University School of Public Health and Tropical Medicine, with a specialty in the application of epidemiological methods for planning and evaluation of public health programs. His M.Sc. in Health Education and Communications and his B.S. in Pre-Med Biology from the University of Southern Mississippi. I present Dr. Emmanuel Taylor.
Did you want me to advance it for you, or?
I think I can get to
Yeah,
it.
just, all right.
It's this one, right?
Now. Yes, sir.
Okay. Good afternoon, ladies and gentlemen. It seems like we lost some of the family members, but I'm happy that some of you, my strong men from Morehouse and the ladies are still here. So thank you for waiting through this session. I'll be speaking to you about some aspects of what Dr. Walker just spoke about, and what that I see that might be responsible, or one of the factors that will need to be addressed in order to bridge what he presented as the failings of health education. Why has it not been as effective as desired? Why are people still not trusting vaccination? Why are people still believing in raw goat milk as compared to pasteurized milk? What is the missing link? Before I go further, I believe one aspect that Dr. Walker has been advocating, and is also in one of the slides that I received, is the need to integrate behavioral and social sciences into medical education curriculum. And I would like to call to your attention, the NIH will be convening a workshop next Friday. So for students and faculty, I encourage you, if you could participate by internet, that you should. I think you'll find it very informative and beneficial. That's the official part of my talk. Any views expressed by me in this presentation are solely that of myself, and do not in caps, represent or reflect official positions of the National Institute of Health or the National Cancer Institute where I work. Dr. Walker presented a number of points that will form the context for my presentation. The accelerating pace of scientific and technological challenge being unprecedented. And of course, he spoke extensively about the focus on STEM. Next, he also mentioned that we all need to be better informed when it spoke about the paradox. There's a great gap between medical and protective knowledge and public's acceptance of the existing knowledge. Whether this is presented to you in doctor's office, at polling places, on the internet, or where else. And this condition exists, as he pointed out, despite advances in literacy and education and all the social media and other technology for communication. And of course, he cited a couple of examples pertaining to obesity and cigarette smoking. And in terms of vaccination, he spoke about parental beliefs, lack of information and misinterpretation of existing information as part of those things that are contributing to the skepticism about vaccination. And of course, I believe he concluded by saying health education is not just awareness of facts. It's not just about providing information. and that the fact that it's less important than insight and your ability to raise interest in nurturing values that will allow people to live healthful lifestyle. That is the context for my presentation. As I go forward, what I will try to do is do some statement of the problem, which is the context. Also offer some operational definitions, so we will be on the same page as to what we're talking about. And I will also share with you some of the things that are being done to address the difficulty and the challenge of limited health literacy. And thank you for your comment in the previous session demanding attention to health literacy. I call all the things or the factors or the issues that Dr. Walker described as the new public health era. It's different from just mere surveillance, doing public health lab work, because of course we saw in Flint, Michigan, that you could even cook up data from state laboratories, particularly when it comes to the underprivileged communities and individuals. In the new era, there's increasing appreciation for the role of socio-political factors as determinants of health, and you've all heard about social determinants of health. Concurrent is this need to better understand the pathways by which those social determinants of health actually affect your health. Even in the face of the emerging explosion about advancements in genomics and information technology. And as he alluded, genomics and information technology per se have been employed to address inequalities or inequities in health and health disparities. However, these tools by themselves will not deliver on the lofty promises without concerted political as well as societal resolve to deal with the social determinants of health. Operational definitions. Again, we hear about inequities, and for those of you from Morehouse, you've heard about my good friend, Dr. Kamara Jones. And she speaks very eloquently about that. And she's even presented the logic between two plants. One you nurture, one you put in the closet, never see the sunlight, and what happened to them. That's the nurturing of the values to maintain. Of course, the British lady back in 1992 defined health inequity as health differences that are, and I tend to underline things that I want you to really take home. You see, health inequity as avoidable, meaning you could avoid it, unnecessary and unjust. Health disparities in this context then are also inequities that are unfair health differences. Disparities by nature is differences in incidence, prevalence, and you might hear people say, oh, there's so many definitions of disparities. No, it's not. I'm an epidemiologist. Fundamentally, you say the distribution of diseases among people and the study of the factors, And the other side is and the application of that knowledge to control or prevent whatever it is you study. So in that context, health disparity is closely linked to social, economic, environmental disadvantages that adversely affect groups of people. And of course, the IOM wrote about the unequal treatment, which are called disparities in treatment, even when people gain access to health care. And we talk about access to care as if it's the do-it-all. The people that we've been talking about since yesterday in the Tuskegee experiment, or I call it the Tuskegee abuse, the Taliban of their time. They gained access, but we saw what happened to them when they gained access. That's why we're here today. And equity is not the same as equality. Okay? I like to use this African adage that you've all heard before. Oh no, say 5 minutes. Getting a horse to the river is not sufficient if the horse will not drink. Getting the horse to the river is getting information to people. Getting the people to bite on the information is actually drinking the water. And I say, what's the missing link? The missing link, in my opinion, between health education, which is the intervention you deliver, and your desired behavioral or attitudinal change. The gap between those two, in my opinion, is health literacy. And of course, in the Healthy People 2020, as well as the American Public Health Association documents, they've declared limited health literacy as a public health problem. And I will not read to you, and you could go through the slide in the interest of time, so you could appreciate the impact of limited health literacy. Problem communicating with physicians or reading instructions and labels. If they tell you to take a medication and somebody's put 2X and somebody go home, how do you translate that? Or they say QID. How do you know about QID? What does that mean? Problem understanding health concepts. Of course, we've learned about the Tuskegee experiment. Of course, they had informed consent. That's why we said they got bamboozled, which means somebody talked to them about participation. We're still faced with our people's inability to comprehend informed consent. And as you heard earlier, the advocacy for people to continue to participate in clinical trials. And according to the American Medical Association, it says poor health literacy is a stronger predictor of a person's health than age, income, employment, education level, or race. And of course, the changing demographics of America will just make it worse, because you have more and more non-English speaking immigrants. The population is getting older, and of course, old people are going to have issues with hearing, with sight, with comprehension, just with acuity. What is health literacy? Definition, operational definition. And I like this particular definition. It also came out of the background paper that Dr. Walker used in his presentation by Nottingham. He went beyond just mere ability to read and write. He went to the benefits, the functionality that literacy will give you, and what you're able to do, the empowerment that comes with it. And I like your word when you talk about empowerment also. It has 3 types of literacy: basic, functional one. And we say we have a lot of functional illiterates in America. Only 12% of the adult English-speaking American adults, only 12% have adequate health literacy, which means 80-something% or short. Then you have communicative or interactive literacy, which is merely your ability to engage me, to carry conversation. And of course, you have the critical literacy. Dr. Warren and my good friend, Dr. Anderson. Critical thinkers, and I'm sure those of you that are their students, you will know they try to make you into critical thinkers. And I think even some of the family members yesterday challenged us during the presentation of that you should not believe everything you see, everything you hear. Don't even believe that cartoon, probe it further to see what is it that the cartoon was trying to say to you. Again, that's critical part of literacy. I think the critical part of literacy is what I would like to emphasize to empower our people. The WHO also has defined health literacy. I like the second part of it. It says it means more than being able to read pamphlets and successfully make appointments. Health literacy is critical to empowerment, both individual and community empowerment. And I copied this other one from the US, the HHS, Office of Disease Prevention and Health Promotion. It says health literacy requires knowledge from many topical areas. So I was very happy yesterday to see students from engineering, students from behavioral, from different fields, addressing the whole issue of what happened in Tuskegee. I call that being conscious and social injustice. Being able to be critical thinker, and I told somebody, regardless of which field you go into, be a critical thinker. It's almost a requirement. And we talk about what is the gap between health promotion and disease and the desired outcome. I will share with you the section on this, on the outcome part, and you could follow through that. Critical health literacy, both on the personal and community empowerment level, improves individual resilience to social and economic adversity, and our people have definitely endured a lot of adversities. On the community level, it improves their capacity to act on social and economic determinants of health. So if you say you want to deal with social determinants of health, I suggest you better make sure you got the community behind you. And improved community empowerment. I'll do like Dr. Walker, I'm borrowing 5 minutes. I'll be done in 5 minutes, sir. If you look at this particular slide, from health promotion actions in the bottom to the intermediate health outcomes that we want, health, lifestyle changes, effective health services, he called it personalized health medicine, and the healthier environment. He also talked about the environmental factors. The distance between your health promotion and those outcomes, again, is the health promotion outcome themselves, and one of the most fundamental of those is health literacy. It has implications for those other two, for the social influence and action, as well as for health policy. We heard that the president and even the former Secretary of Health, Sullivan, apologized for the Tuskegee. Trust me, they gained their awareness through some health literacy, and they went on to make such a public policy, even up to this human subject protection. We saw what is the benefit of the legacy of Tuskegee. Part of it is those health policy and organizational practices to ensure that it will not happen again. IRBs, all of those things that we heard that came up are fundamental, and they were based on literacy and empowerment of the community. I will quickly kind of go to the examples of what is being done both at national, local, state level to try to deal with health literacy. And I'm addressing this more so to the students and the faculty in the audience. To some of you, the students, consider some of these things your call to action. And as I go forward, you will see why they are more pertinent for you. Improving health literacy is critical to achieving the objectives set forth for Healthy People 2020. We are in 2016, which means in 4 years' time. All of you would have graduated, practicing. You will be the one to implement whatever comes up. In addition to Health People 2020, there are initiatives both at the federal, non-governmental organizations, institutions, at the national, state, and local level, trying to do different things. And I'll give you some examples. And I urge you, if I don't get to the depth of this, please Google them. And if need be, obtain copies of my slides. This is in public domain. The National Action Plan to Improve Health Literacy, the Patient Protection and Affordable Care Act, the National Class Standards, and somebody talked about being linguistically, culturally appropriate. There are some standards, 15 of them, that are said that make up the class standards. Of course, there is also the Surgeon General's National Preventive Strategy, which is to go from disease to prevention. He even went when Dr. Ruben Warren and myself and others who are CDC, Dr. Sacha literally obtained the authority to change the name of CDC to attach and prevention. Some of you would not even know that and prevention was not part of the name of CDC before, but he managed to get that in. And when he became Surgeon General, he definitely made it his first platform. Of course, the cooperative extension, of which your school here, Tuskegee, is part of them. Majority of the HBCUs, whether it be Morehouse, Spelman, Morgan State, Jackson State, wherever, Tugulu, They are all part of these land grant universities, as they call them, and they have a group they call the Cooperative Extension. Also, there are collaborations across sectors. If some of you listened to the news yesterday, you will know that the president just met with a number of CEOs of corporations, and Victor will be happy to hear this, to talk to CEOs of major multinational, international corporations to change their views on previously incarcerated young men and to find a way to hire them so they could become productive members of society. That is also empowerment. I will give you an example of two that are somewhat related. This National Prevention Strategy and the Cooperative Extension. I want to show the national and the HBCU. So how do we fit in helping our own population and communities? The goal for the National Prevention Strategy is in the center, to increase the number of Americans who are healthy at every stage of life, from when you were born to the day you meet your maker, to stay healthy in between. It's called the life course perspective. And of course, they have those 4 strategies they want to use, or goals. Health and safe community environment, elimination of health disparities, and of course, empowered people, which means community and individuals. And on the outside ring are some specific activities and initiatives that you're all aware of. Tobacco-free living, injury and violence prevention, mental health and emotional well-being, active living. That's why you have all these bicycle lanes and jogging trails. And for the Council of Land Grant Universities, which is mostly HBCUs, you will note that they share the goal at the center to increase the number of our people who are healthy at every stage, but they are using what they call the social ecological model. And based on what they know that the universities could do well, they pick those 2, which means healthy and safe environment and healthy and safe choices. They believe those, the university could play a role. And in the next domain is what their priorities. So if you're looking for what you're going to do for your thesis, for your dissertation, or what do you do after you graduate, pick one of those they call the priorities, the orange ones. And of course, you will see that one of them is health literacy, and the other side of it is health policy issues and education, and at the bottom is positive youth development, so we don't have 16 and 17-year-olds killing 13 and 12-year-olds, to where even the grown-ups are afraid of their own children. And of course, the Cooperative Extension have also developed logic model. And for those of you that have taken courses in program evaluation, which is what I do, you know we cannot live without logic models. It's the roadmap. Again, I've mentioned to you we're trying to understand the pathways by which all of these things interact. Critical thinking. Look at those arrows and create your own arrows. Do research to verify if this conceptual framework works. If it doesn't, modify it. But take on yourself, if you modify a conceptual framework, you're committed to deliver on the modified version. In conclusion, within my remaining 1 minute, 0 + 1, health, education, and health promotion are necessary. As Dr. Walker said, they are one of those tools for addressing modifiable determinants of health, in empowering individuals and communities to make health choices and live in healthy, safe environments. These goals cannot be achieved without improving the level of health literacy in the American society. Improvement in health literacy should be a clear, defined outcome of health education and health promotion. It should not be an afterthought. Don't just say because I put the pamphlet out and I spoke to them, they will understand and use what I said. As Dr. Walker said, they're not buying it. So you cannot make it just some afterthought. Make it a conscious, deliberate thing to target. Improving health literacy will require innovative strategic approaches both at local, state, and national level, by educators, health professionals, as well as health professional organizations, the AMA, the NMA, the dental folks, and I'll put in there the fraternities and sororities. I'm a Phi Beta Sigma, but I don't see any boundary because my big brother is a Q. And my best man when I got married was an Alpha. So, and I married a AKA. Got off of that and married the Delta. So, we all have a role to play if the various national and local goals are to be achieved. And when I say we all have a role to play, please put yourself in there and say, what is my role? What can I do? What should I do? You've heard about patient navigators, created by Dr. Harold Freeman, African-American brother in Harlem. Be your own health literacy navigator for your family, for your bodies, and for the community. We talked about yesterday about sharing information. They said, each one teach one. Is your brother in too heavy, pull him up. Those are all the fundamental things we learn, including I'm black and proud. Those are all the things we grew up with. It's why I could go to Mississippi and be an honor student. Find your role, play that role to the best you can. I don't want to preach, go read Romans chapter 12. Right. You are all parts of the same body. And it's the body I call the community of color. Whatever you choose to be the best at it. Your teacher, be the baddest teacher. You're a cook, be the baddest cook. I go to Harlem, I like to go to I go to Sophia's or Sylvia's, whatever in Harlem. There's one in Atlanta. Whatever you choose to be, a dentist, a nurse, occupational therapist, people are living longer, they're going to develop arthritis. Collectively, we could keep our communities from being abused. Again, promise yourself, and I asked yesterday, what will you do in your era? Promise yourself that it will not happen on your watch. Thank you.
Now we have our second response from Dr. David A. Anderson. Dr. Anderson received his DDS degree, Doctor of Dental Surgery degree from Howard University, Master of Dental Science, Prosthodontics from the University of Pittsburgh, and the Master of Arts in Bioethics and Health Policy from Loyola University. He completed general dental practice and prosthodontic residencies in the Veterans Administration. He maintains an active private practice and has served as Assistant Professor of Prosthodontics and Director of Diversity and Inclusion at the University of Pittsburgh School of Dental Medicine. He is a member of the American Dental Association's Council of Ethics, Bylaws, and Judicial Affairs. I present to you Dr. David A. Anderson.
Thank you. Before my time begins, I'd like you to join me in taking 3 deep breaths. Okay? This is the first one. Hold it, hold it, hold it. Let it go. That's 1. Second one. Deep breath in. Hold it, let it go. Third one. Deep breath in. 4, 5, 6, 7, 8, 9, 10. Very nice. Well, I'm feeling more comfortable. Thank you very much. My presentation style is actually to overwhelm you with different visual images and give you enough data so that you feel like you're drinking from a fire hose. I have 29 slides and I expect to go through them in 13 minutes. So now we're beginning with the end in mind. My time hasn't started yet, is it? Okay, you ready? Thank you. In this market-driven economy, free market-driven economy, we're hearing more and more language of economists and philosophers relative to healthcare and consumption of healthcare. I'm so very privileged to be in the same space, and I mean this, with Dr. Bayless Walker. Thank you very much, sir, and my new colleague, Dr. Taylor. So I'd like to talk a little bit at first, would you? Thank you. At first, about the concept of economic externality. An externality actually occurs when the production of a good or service imposes a cost or a benefit on third parties who are not involved in the consumption or productivity of the product of service. Now, externalities can be negative or they can be positive. In this particular discussion that we've had, the challenges to health literacy are actually a negative externality because the people who will pay for its provision aren't the beneficiaries. However, the conversation that we've just had with Dr. Taylor talking about the realization of health literacy and health equity actually is a positive externality. With respect, gentlemen, I'd like to contextualize your comments relative to that economic term of externality. Next one, please. We had a chance in 2008 to really evaluate what society was that we didn't believe it was. Next one. And in doing so, we had a chance to look again at some of the contemporary ethical frameworks. In the first one, a fellow named Englehart, H. Tristan, was a priest who had a crisis in faith, left the faith, had a crisis in reality, and came back to the faith. And so he wrote about whether or not you can actually have a morality without a spiritual impact, the canon, the Bible. Can you have a morality based on something other than the Bible? We thought we were post that, but just 6 months ago, we had a visit, an official visit, 6 months ago, an official visit, and the world's attention and the United States' attention were moved to the voice of the Pope. And his encyclical, the papal encyclical, focused us on 3 issues: human dignity, back to that, an emphasis on immigration and fairness, and the concept of an emphasis on treating our environment as wise stewards. And all of healthcare actually is based on ethical and religious directives that are part of papal encyclicals. That seemed a little theoretical. But now let's talk about another concept, and we'll spend a few minutes on this. That concept is the common morality. Now, there's an easy way to do that. Common morality says what's common among us is valued to us. Let's do a simple illustration. Would everyone or anyone who has non-corrected 20/20 vision and is not using any visual aid to see the screen, if you're not wearing glasses or contacts, would you stand up, please? Okay, look around. 1, 2, 3, 4, 5. Okay, you all are the only, please stay standing. Please stay standing. This is important. Since you all are the only one who really can see this and understand what I'm saying, then you're the only ones with full personhood, and I'm just going to be talking to you. Because the other people they can't see it, they don't matter. And we can take any characteristic like that, define what is common to us, assign ourselves personhood, and subtract that from someone who's not like us. That's the common morality. We're going to take our country back. Thank you very much. Have a seat. I'll just give you a minute to read this one. There are several oxymoronic statements in here. The common morality, ethics, the part of ethics that defines the common morality takes shared beliefs. Now, how many shared beliefs do you think the two of them have? And it motivates, how motivated are they? Our collective and individual actions. There's some dissonance and disharmony there, but that's some of the basis of the shifting sands of common morality. I included a study of Hookless and Hoped. This was from Reuters, and it's in the references. It just talks a little bit about what's happening in our nation relative to substance dependence. Let's call it that, a neutral term. But every 19 minutes, probably 4 babies, since we started talking, have been born that are dependent on heroin. In 2003, there were only 5,000 in the nation. Now there are 27,000. We do some neonatal testing, but the HIV and the phenylketonuria test don't test for this. In fact, the onset of neonatal abstinence syndrome, which is actually withdrawal from heroin, occurs about 3 days after the delivery. However, with our new paradigms of care, you're lucky if you stain the sheets in the hospital these days. So you're discharged, if it's a non-surgical delivery, within in a day and a half. The problem that brings along, the collateral damage is significant, and it's most significant about 150 miles from Pittsburgh in Huntington, West Virginia. You can see what the statistics are. The national statistics are 7 in 1,000 live births have this withdrawal syndrome. But in Huntington, West Virginia, a town of 50,000 people, there are 139 per 1,000 births. They occupy 67% of the NICUs, and they've added an additional 17 beds for that. We can fix the babies. If we have the babies for 4 days, we can put them on methadone and they're done. One of the problems, though, is that mom and dad can go out and get refueled, and when the baby's symptoms evidence themselves, they're in no condition to offer anything but danger. But those are the facts. One of my favorite philosophers, and actually professional models and mentors, has said text without context is only pretext, and he's giving autographs this afternoon as well. Sir. But the story is being rewritten. You see, heroin addiction, especially in West Virginia, since it has reached the majority population, it is being recontextualized from antisocial criminal behavior to suicidal ideations, and within the realm of intentional self-injury. Now that's abnormal, but it happens in acceptable situations. So it's being recast. So this is the time, once we've recast or contextualized the issue, because when it was in the minority communities, it was just pretext. Now it's become central, contextualized, and now we need to develop what I learned last night is called compassionate public policy. Thank you for that. The reference is given. And so social justice is applied. Just about 6 weeks ago, for the last 10 weeks or so, you've been hearing about congressional funding for opioid dependence. And the president has an idea of what he thinks it will take, and so does everybody else in Congress, so that agreement is an issue that will lead you to some kind of dependence. The challenges, which would be the negative externalities, include the working of the child welfare system, and then the death rates for NAS. The babies don't die from the syndrome, the babies die from parental action and neglect. Issues of infant custody are challenges, and collection of evidence, especially in these smaller areas, smaller places, when you have parochial constraint, or states' rights, to determine the standards of reporting are there, but the praxis of reporting isn't always consistent with the standards. And then the responsiveness. This, by the way, this is the Dirksen building, the Senate, where the Senate debates are going on. Thank you. The opportunities, which would actually be the positive externalities, include the way that the funds are distributed. They're distributed in community development kind of block grants, which are applied to people with full personhood in the parochial settings. He's talking in code. I'm supposed to be able to speak plainly here, but I am speaking plainly. There are also regional partnership grant programs, which are administered the same way. Children affected by methamphetamines, the CAM programs, if you're in the industry, you know about these acronyms, and you know how they are being applied toward the problem. And then here's the other problem, or an opportunity, let's define it that way, is that the medical criterion for treatment is not directly connected with how the courts see this substance dependence issue and its collateral damages. So here are some other opportunities. The data collection and reporting has been standardized. We can also access quality substance use disorder treatment, that's accessible, and improvement of collaborative practices and the tools available are also a way of public policy showing compassion. And the last part, the last of these ethical paradigms are the ones we're probably most familiar with, and I know you're developing practice ideas according to Beauchamp and Childers. So you've got beneficence, non-maleficence, autonomy, and justice. Here in the state of Alabama, the Dental Practice Act #1 was first made shortly after the Civil War. This is the first state to actually have a Dental Practice Act and law. And shortly after that, the dental profession has came up with dental ethics, which have remained unchanged. Interestingly enough, the principles, the 5 principles of ethics, can remain unchanged because about 90% of dental issues are infectious processes. And that should ring a really special bell here in Tuskegee. There is no place, no time, no person that should be a reservoir for any type of infectious process. And that's why ours have stood the test of time. And they look like this, and I'd like you to see them. This is brand new. This was released on Thursday at 3 o'clock. And I got the ADA's permission to use this image a couple of hours ago. And I'd like for you to see it. We're helping develop engineering ethics because they've seen that we've kept this code for 150 years. We're celebrating this as 150 years. So I would suggest to you to take a look at this as you provide professional services and as you consume professional services. What's at the top? Patient autonomy. It's got to be up to you. You belong to you. And so the choices presented to you need to resound that you're autonomous. Secondly, you need to know that there's non-maleficence. And across the diagram from non-maleficence is veracity. Veracity is the ability to communicate with you so that it inspires trust. Beneficence and justice. So I would just suggest to you that as your practices develop, as you're looking at public policy, how you will vote, what's going on, how you will vote medically, as well as engage politically, let's take a look at those. There are references here. There's contact information. And to those who have gone before and are still marching, engage readily, become disciples, and don't be afraid to ask any questions at all. Thank you.
At this time, we'd like all our speakers that we had to come up to the table so we can have our panel discussion like we did the last time, please. And if you have any questions, raise your hand so we can bring the mic to you. Are there any questions right now, or would you like them to go ahead?
Yeah, straight.
It's always exciting to have Dave Anderson respond to specifically my presentation. If you listen to Dave, you thought I had given the Gettysburg Address.
Absolutely.
And I don't know whether or not Dr. Warren does this by his intentions, or it just happens that way. But I always enjoy listening to Dave because he's really responds in such a way that he takes what you said and fit it into what he knows. And he does it with a lot of class. Thank you, Dave.
I'd like to take this opportunity to do something I didn't do while I was speaking, which is to sincerely thank the organizers of this session, particularly my new discovered cousin, Dr. Wylin Wilson. I'd like to thank my big Egbon, which means big brother, Dr. Ruben Warren, and Dr. Katz. Thank you for what you're doing to stimulate critical thinking in these young people. Much, much appreciated that session last night. Yeah. They said life is a learning process. And I have to tell you, sir, I learned something from your presentation. Well done, well done. And that said, to you students and faculty on this campus, I would like to just express to you how jealous I am of you. That you get to walk around on these sacred grounds every day. Keep in mind the people that went through the Tuskegee abuse and the founders of this university. And make something of yourself.
Questions?
Well, I have a question.
Okay.
You did say we have to take it into our own hands to make sure that health literacy gets out there. What can we be doing right now in our own hands to help it get out there in health education and things like that?
That was Dr. Taylor's, and I wouldn't dare take that privilege away from him. You commented on that.
I'll respond to that by going to the...
Can you read the question again?
Restate the question.
I'll let her say, so I don't...
I was just saying, they said it's important that we get health literacy out there because without health literacy, people aren't going to be in the know. So what can we do right now to make sure that we get it out there in health education? That was my question.
And from our presentation, I guess, hopefully you could differentiate between health education and health literacy. And that's why I use the terminology, getting the horse to the river and getting the horse to drink. What I would suggest that you could do almost readily is something that you're holding in your hands. It's called your mobile phones. Even the precision medicine, they will be collecting data from those 1 million volunteers. using mobile phones. You all have Facebook, you have Instagram, and all those wonderful things. Start with your own cliques within your network. Share information that you know. And we said it verified yesterday. We corrected from 300 to 600 human subjects yesterday. That's one thing. Correct some of your colleagues that I've heard about Tuskegee. Oh, it wasn't 300. I learned yesterday it was 650 or 623. Take any information that you know. For instance, a good one right now is access to insurance through the Affordable Care Act. Take it upon yourself to educate our people. I shared an article with Dr. Warren that says precision medicine with imprecise ethics. And that was the question I was asking the gentleman yesterday. What will you do in the genomic era? So educate our people to know enough about simple things such as insurance premium, concept of co-pay. When we have our people with limited health literacy trying to enroll in the Affordable Care Act, simple things as premium and co-pay becomes a daunting task. So take it upon yourself, like I said, be a community navigator. We say patient navigator. Help people to access things they need to know. Whatever that you know for sure may not be a popular knowledge, share. HPV vaccine, cervical cancer, for instance. The uptake of those. There are fundamental things you could do. And I would just suggest, they said knowledge is power, but it's only powerful when you could relate it to somebody else. If not, it dies with you.
Let me confess apologetically, but I think this is a major task. And yet, if we do not help increase the level of knowledge at the rapid pace that it is changing, I think the final impact of that increase in knowledge will be diminished. And I think if you go through the literature, you will see prominent examples of how fast things are changing. One minute we were talking about personalized health care, and the next thing we knew in the State of the Union address, President Obama was talking about precision medicine, which he meant the same thing. And as we probe further into the new terminology, we all were thoroughly familiar with chicken pox. But there are very few people who can talk about chikungunya, the disease that started in India and moved rapidly through the western section of the country. And so there's rapid changes going on. And the terminology is confusing to a lot of people. And the question is, how do we bring along the population, total population, such that they are knowledgeable and can communicate and can understand as they go into the healthcare arena what these terms mean. And that is why I think we need everybody on board to help move this process forward. And that is why I think, yes, STEM is an important and a needed emphasis if we're going to compete in the world or global economy. But at the same time, there are some fundamentals that people need to have if they're going to function properly in the healthcare system. One example I like to use is the simple term one payer, single payer. And you can ask, and I have done this, I've asked people, do you like single payer? No, I don't like single payer. No, don't talk to me about single payer. But do you like Medicare? Yes, oh yes. Medicare is single payer. And so I think these kinds of pieces of information are very, very important. And we've got to figure out a way that we bring the population along with the progress that we're making in advancements in science and technology, and certainly in the health area. Yeah.
So when you think about, we're talking about making healthcare, just the understanding of just health literacy with respect to not just physicians but patients. So I think on some level you have to start again, like I said before, with educating the physicians. But at the same time, I think you need a system where the way people access healthcare, that it's not so reactionary, that they only go when they're sick, that there's a system in place where people are able to do preventive care, things like lifestyle medicine, so that when they go to the physician, that they're not sick, they're not seeking medication, but they're going for health maintenance, and that the system is in place that allows them to do it, whether it's to make it affordable, make it free, so that when they go and they access care, that the physician actually has the opportunity to educate the patient about what's the next steps and how you can maintain or reach a healthy lifestyle. So it's difficult to educate when patients come only when they're sick, or they're seeking medication, or they have a medical problem. Because on some level, they are just trying to get better so they can go back to work. But to have a system in place where when you have health maintenance, and you have the understanding what a healthy lifestyle is, how you can actually attain a healthy lifestyle, but you have to have provision and funds and an understanding boss. So it's really so kind of complex that in order to really get to that, to get to what you're talking about, where we can actually educate our patients in a reasonable way. So how do you even get there in the system that we function in right now?
I'll like to answer that.
Go ahead, Dave.
She could probably hear you.
It's healthcare actually it's removing the responsibility for your wellness to someone else. It's transference. We used to, healthcare used to be relational, now it's transactional. And because it's transactional, it becomes politicized. And so you dispossess you, and you dispossess the health giver in the options available to you. So I would suggest avoiding incarceration in such a system. Take responsibility for you, because you actually trust you more than anybody else you're going to let touch you. The other piece is that compassionate political activity is further dispossessing. You know, when this Senate Bill 5, I think it is, sails through to try to decrease opiate abuse, the reason that you come for medical care is because you're in distress. And the new guidelines for prescribing are only going to allow what's in your medicine cabinet. The use of ibuprofen, the caregivers, and you aren't going to see the physicians, but the caregivers that will be on the front lines will have restrictions on what they can give you. And you know, our need for pain resolution is more than neurological, but compassionate public policy is restricting your ability to have prescribed pain relief. So take responsibility for you. You own you. God has given you responsibility for you. He didn't leave it at the hospital or your doctor's office. So try to stay free of incarceration of the system.
thinking as from a healthcare professional perspective as a physician, how do I, or one as a physician, empower, release the patient from this incarceration you're speaking of? Because it's not like it's not a blame game. It's sort of how do we together come to a point where the patient does not feel that they're in that position of this incarceration you're speaking of, and I, or my colleagues as physicians, approach someone who is seeking resolution of a problem, but at the same time are able to influence or impact their lives in a way that they begin to think beyond their current problem to preventing further incarceration or issues or medical issues, but sort of proactively. And it kind of all goes into play with this, the whole new sort of push in medicine about lifestyle medicine, managing in preventive medicine, how your lifestyle and preventive medicine can prevent disease. What can you do on a day-to-day basis with exercise, what you eat, what you smoke, what you do to yourself, smoking, drinking, those kind of things. And then not only tell people about that, but provide them opportunities to eat a healthy diet. You live in an area where there's a food shortage, or you don't have access to a grocery store, you don't have access to fresh vegetables. It's very easy for me to say to a patient, you need to eat 5 to 6 servings of vegetables, you need to be able to walk 30 minutes a day, 5 days a week, but you live in an area where that prohibits, you don't have a walkable neighborhood. There's lots of stray dogs, because stray dogs are a really big deterrent to walking. You don't have a bus system, you don't have a car. The only store in your neighborhood is the dollar store. You know what I'm saying? So how do you manage all that?
Understood. I don't intend to minimize what you're saying at all. In fact, it's the essence. It's the essence. But let's see if I can distill it. I've been in essentially the clinical practice or training for 41 years. And so it's real to me. It's real about having relationships with your patients beyond the 6 minutes that vertical integration has caused us to have. But I think personal choices and lifestyles, so they ask you and you project something. When I was here last, I weighed 85 pounds more than I do right now. But I decided to take responsibility for myself and not be dizzy from being medicated imprecisely. I decided to live. And you know what people, first thing is, in my practice, I see myself as helping people feel better about themselves and to be better. And so I project my best and they ask me, and some of you have asked me, wow, what are you doing? That develops the relationship and it kind of dispels some of the other peripheral issues. Thank you.
But I think also the physician often has a teachable moment. And I've been told by physicians that the best time to talk about smoking cessation when you have a case of respiratory disease before you. That's one way. And I think we cannot ignore the payment process as influencing behavior. And I apologize for this example, but it's one I know best. I'm a graduate of the University of Minnesota, and we have that close association with Mayo Clinic. Mayo Clinic pays its physicians a salary, and therefore they have time to do many things. The ophthalmologist at Mayo Clinic, if you go in with the problem, involves the eye, they will sit and sketch the eye and explain to you exactly what your problem is, or why you need cataract surgery, et cetera, et cetera, et cetera. And they take the time to do that, and the payment system allows them the time to educate the patient. And their reports suggest that because of the educational process that is in effect at Mayo Clinic, they achieve a high level of effectiveness in dealing with a patient problem. Now, not every clinic does that. I don't know of any other clinic that does that, but I know that we go back, those of us who graduate from Minnesota go back and spend a few days during the summer learning what's going on up there. And that's one of the things that came clear to us just last summer. And they've done it for a long period of time. And a colleague of mine said, yeah, now we know why people fly into Minneapolis and get the bus down to Mayo Clinic, because of the quality of care. And I think there are many other examples. Cleveland Clinic is a good example, and the list goes on and on and on and on. But behavior of physicians can to some extent be dictated by the payment system. That's the point that I would make.
Hi everyone, my name is Nixon House. And the question, to a point that the doctor made on the other end, what do you guys think about incorporating the organized religions to be able to delegate this responsibility back to the community? Because every week we all gather in a place of worship. A good majority of us. And I think, for the most part, a section of that service or a type of advocacy should definitely go into creating an infrastructure to allow people to have a health ministry within their organized religion. So I was wondering what it is that you guys think about that aspect of delegating this back into the community for the wellness of that community.
I think that's a pretty good question. I will not go back to Romans 12. I'll pick another one. I just want to call to your attention that the Department of Health and Human Services does have what they call faith-based initiatives. Look on the HHS website for faith-based initiatives and see how you could help your church, your denomination, or whatever, to take advantage of the funds that are available to support ministries, organized religion, to incorporate health messages. I think it's well recognized the role of churches and spiritual organizations in communities and their influence over time. A lot of the HBCUs you see also have churches or ministry as their foundation. Morgan State is Baptist, even all of you at Morehouse, I'm sure they take you to Ebenezer Church every now and then. So the role of religion in communities is there. I remember earlier time in the HIV/AIDS, CDC, with the leadership of Dr. Warren, actually sponsored workshops for ministers how to incorporate the whole HIV/AIDS message for prevention and community advocacy to their ministry. So it's not about ostracizing gay or you HIV positive, so now it's because you sinned and God is punishing you and those kind of stuff. It took some structured, conscientious effort for people to not keep condemning people because you're HIV, so it means you're sinful. I think there are structures, and I think what you could also do, which I tend to do in the church where I go, because we do have a lot of Africans in the church in Baltimore where I go, and I still drive almost an hour to go there out of relationship with the pastor. I'm believing that the person reaches me. So I still go there, even though I pass a number of churches going there, but I have a commitment there. And what I tend to do is get involved with the health fair. Organize health fairs at your church, get the local health department to donate blood pressure cups. Hypertension is still a big issue. Work with some local physicians that have clinics in your neighborhood Well, if you're my neighborhood making money and you think you're treating my people, well, come help us to also eat right, to live right, to not smoke, and not beat up spouses, those kind of other stuff that also are social determinants. So you could actively get involved, not about delegating to the churches, but actually partnering with the churches. Churches are not just buildings, it's the people in it. So make yourself part of that and be an agent of change. They say, be the change you want. Obama says it all the time. Be that change that you want to see and be one of the catalysts to make it happen.
Some of the physicians in the Washington, D.C. area have videos that are played if you're in the waiting room that I find very educational. And perhaps we may pursue more of that because it's one approach to health education. And it's a very effective approach according to the feedback we get at the university.
Well, I'm moved by Romans 8 that there's therefore no condemnation. I'm sorry.
That's why I didn't take 12, I went to 8.
And the end of that about no separation. Two things. One is because church has become less central in our communities, many efforts are funded by philanthropists or outside interests, which have interests that are outside, which leads me to the poignant moment of us being here. It was church and school-based clinics that the United States Public Health Service used. So, that brings me to the matter of veracity. So we need to communicate in our communities so that trust is developed and trust is nurtured. So we want to be very careful who we invite in and what we're doing and where the data goes. Data isn't often depersonalized. There aren't honest brokers in the process. In all thy getting, get wisdom and understanding, and you can actually project the solution as opposed to being dependent. Interdependence.
Are there any other questions?
Sounds like you covered the subject extremely well, sir.
Do you have any other statements that you would like to make this time at the panel?
What an honor it is to be here. Legacy tending and legacy mending. And you are part of the talented 10 who have been empowered, and now it's your responsibility to empower others.
I think we ought to thank this group for being here, listening to this. I've always dreaded after lunch speeches. After lunch and after banquet speeches are the worst places in the world to give a speech. But this group is here and attentive, and you've raised some very fundamental questions, and I think the discussion has been very, very productive, and I would like to thank you. Yes, there's a question there.
Thanks. I do have a question. I've been thinking about the comment that you made, Dr. Walker, about the fact that although resources have been put behind obesity, research shows that not much has changed with that health issue. You also talked about the need for attitudinal as well as behavioral change. My wonderment is in regards to health education and literacy, how do you help jumpstart the heart of the people who are on life support because of so many inequities and injustices within the system that you're conscious of, very aware of, have had to live with, deal with, and within a society that has taken away so much purpose for living. Because as you, Dr. Anderson, shared about your own transformation and making a conscious decision to take ownership of your health and well-being, lose weight, get healthy, and various things that you did, to me that speaks to one who is not disassociated from self. And you're able to make that decision with follow-through action. So many of us, particularly in our communities, are so self-disassociated that there isn't enough of a connection to even hear the information, take it, process it, and then take action such that there is a change in outcome. Because so often there isn't any, we don't see where we fit in to life, to society, to be able to have motivation for the kinds of changes that we're talking about. So I would like to hear some responses to what you found perhaps works, or what your suggestions are around helping to give people a sense of purpose for being.
To respond to what we do this shot.
When the Pope came to the White House and subsequently Congress, he talked about the concept of human dignity, which is the secularization of being made in the image of God. And I would argue that he took his text from Romans chapter 8 and said, we need to leave that condemnation behind and live with a certain freedom, and society needs to do that for us. So I'm not quoting scripture, I'm quoting a papal encyclical, if that's enough authority. So how do we do that? We embrace the freedom that is ours, and then we live as free. We live empowered lives as free. Our bodies aren't full of chemicals that we don't know about. Our families aren't affected by some dissociative behaviors that society has imposed on us. Or I was sitting next to Dr. Warren at lunch, and they brought him some salmon. He said, I'm a vegetarian. I think he's free. That's how free men act. You don't have to eat what's placed before you. This is my body, and I don't put things that were alive inside of it. So be the Dr. Warren in your community. Stand up and say, I'm taking responsibility for me. The same time that you take to care for others, put yourself first. Come down to the Zumba class at 7 in the morning.
Can I sit down?
6:30.
Excuse me. Yeah. Just to contribute to what my friend just said, I think one of the things lacking in health education and health literacy efforts that we are also trying to correct, even at NCI where I work, is that we do not tell our people good news enough. We tend to be messengers of negative outcomes. We're dying at higher rate. We're bad off, we're worse off, we're this, we're that. That's why I say I'm black and proud. I came from Nigeria with that attitude as a teenager. Started off in Mississippi. When I came to this country in '72, Negroid was an official race classification. And we went from Negroid to Afro-American because we all had Afro. You can't tell now. We all wore shags. Maybe that's why my hair started going backwards. But I would say we need to start telling our people some good news about ourselves. I think children are growing up, forming their own self-esteem. We talk about self-image. You see yourself bad, you act bad, you live bad, you get bad outcome. You see yourself good, good things, I believe in karma, comes your way. So let's tell our people more good news about our communities. And I feel strongly about that.
But good news doesn't draw as much attention as bad news. I had a newspaper editor tell me once, would you buy our paper every day if we reported that the plane arrived on time every day? No, you wouldn't. But if the plane crashed, you'd be the first to rush to the newsstand to buy it. So good news is great, but it just doesn't seem to attract the attention that bad news does. And we wonder why. Maybe that's a task that we need to try to
Yeah, that's true too.
change.
But
Yes.
if you know a plane tends to be on time and you need to book a flight, I think you will know which flight to book.
Are there any other questions at this time? All right, we would like to say thank you, and we really appreciate hearing what you had to say today.
Thank you.
Gee, you really are looking good. I like that. That's great. Mr. Walker. Yeah.
It's a pleasure to see you.
Yeah.
I pray we'll see you again 10 years, 20 years.
I was glad that you really went into that whole literacy piece.
Yeah.
That was really right on target.
My first thing is to look what was the article behind it.
Yeah.
And then I read it.
Yeah, good job.
Let's see that.
How you doing?
Good speech.
Good.
Good lecture.
We've only just begun. We're gonna have a break, but we have a very exciting tour schedule. Every year we go to two places. One is the Multicultural Center that was established as a part of the apology activity. And you've heard a lot about Attorney Gray and the lawsuit and the settlement, but you haven't heard it from the man who did it. And if you did, you need to hear it again, because every time, and I've heard the story many times, it's different. The story's not different, but I'm hearing something different. So we've taken great pains to organize this session with Attorney Gray, and it's always a sellout crowd. That's part of that. That's the icing on the cake. You'll get a chance to understand this place called Tuskegee and Macon County. What you'll hear, in the Multicultural Center, he's traced the different populations that has lived in this city and why Macon County. And you probably don't know, and I didn't know until I got here, that Tuskegee is a Native American name. And the folks who were here were Native Americans. And he's got, in the Multicultural Center, it's detailed in fantastic and very impressive ways. So you don't want to miss that conversation. And he talks to us. Rarely will you have an opportunity to talk to a 80-something-year-old attorney still practicing full-time and has the stories. When I first got here, Attorney Gray said when he went to Alabama State, from Alabama, went to Alabama State, and wanted to be a lawyer. Couldn't go to law school in Alabama. So he went to law school in Case Western in Ohio, and said he was going to come back and stamp out every instance of racism and discrimination in Alabama. And you hear those stories, and you got your books that details many of those stories. But to hear it from Attorney Gray is just a don't miss experience. Equally as important, the Multicultural Museum, and let me tell you this story. When the lawsuit was settled, as you know, there was a financial settlement, but nearly enough, because I don't know how much you pay for suffering. The Bioethics Center was established as a part of the apology. And also, Mr. Pollard said to Attorney Gray, I want to establish a museum so that the community can really understand what happened and something about this this city and this county. And somehow in the process, the museum got misinterpreted to be on the university campus, because that's not community. So there's a wonderful legacy museum here on campus, and it is fantastic. But there's also a multicultural museum, which was the original intent, and Attorney Gray built that museum, not with any federal dollars. And you will be just overwhelmed when you see the power of that place. And you'll get a chance to see this downtown Tuskegee. You can see it in about 2 minutes, but it's something you want to have seen. So we have taken great pains to organize. So at 4:30 in the lobby, the bus will take those of you who want to go, and all of you really ought to go over there. There's a reception plan, wonderful, good food, good people, and really good conversation. So really go and see that. That's the first experience, and it's irreplaceable. The second one is tomorrow night, and we're going to take you to Shiloh Baptist Church, where the men were actually picked up when they were involved with the syphilis study. And you have heard of the Rosenwald schools. Those were schools that were established to educate African American children and adults. And one of the Rosenwald schools is right next to Shiloh Baptist Church. So we're going to take you to see that. And I don't know if we're going to do it this year, but we in the past, we've stopped by the cemetery where many of the men were buried. So we got some really good stuff planned, and we will be offended, to be quite honest, if you don't show up. So take the time to join us. We put a lot of effort into it, and we know that you will enjoy it. So we're going to meet in the lobby at 4:30 and take the bus to the Multicultural Center, and it will be good. Okay, so until that time, we have a break. Doc, we got a break, so we got about 30 or 40 minutes. So again, thank you for your engagement, and we'll see you at 4:30.
But downtown, you know, is short.